Welcome to Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, we are joined by Chris Trygstad, the Vice President of Product and Data Protection Officer at Biomedix. Chris is a dynamic leader with nearly 2 decades of experience bridging the gap between marketing strategy and product innovation. His journey is unique. He didn't just market health technology, he helped build the ecosystem that supports it. At Biomedix, he has spearheaded the organizational pivot to digital health for value-based care, focusing on detecting chronic conditions like peripheral artery disease early to save lives and reduce costs. With background that spans B2C success at Miracle Ear to complex B2B strategies for accountable care organizations, brings a deep understanding of data, policy, technology intersect to improve patient outcomes. Chris, welcome to Health Tech Heroes.
Thank you, and thanks for the introduction.
Chris has spent 18 years navigating the complex waters of healthcare marketing and product development. But before we get into this strategy, I want to understand why. Was there a specific moment or a patient story early in your career, perhaps during the time looking at vascular assessments, that hit you emotionally and made you realize this isn't just about business. We are literally saving limbs and lives?
I think early on at my time at Biomedix, one of the things that really struck home for me is at the time I was leading a team, didn't really have a lot of interaction with the people who were using the device or the people that were being tested with the device. Through my work, I ended up, long story short, I got a call from a patient, and they had a study that they were concerned about, and they were trying to get some guidance on it. And it was just kind of an eye-opening experience for me. It was the wife of a patient who was tested and wanted me to explain, what do these test results mean? I've tried to call this doctor and never really got a satisfactory response. And it really did kind of strike home with me. We're seeing things in terms of numbers and devices and technology, but it really comes down to delivering good care for patients to help optimize those outcomes and keep, hopefully, bend that healthcare cost curve.
And you made a fascinating transition from a pure marketing director role into vice president of product and data protection that requires a massive shift in mindset. What was that personal frustration or ambition that drove you to move from telling the story of the product to actually shaping how the product works and how it protects patient data?
It was really kind of a culmination of me working with leadership at Biomedix. We saw some great opportunities with value-based care. We had been working with interventional cardiologists, interventional radiologists, vascular specialists, and primary care physicians to get our devices in the market and to test people. But we saw this value-based care space, which typically included larger enterprise class customers, including payers and risk-bearing medical groups, and started kind of researching that spot and quickly determined that the device that we already were making, that were in, about 1,000 doctors' offices. We shipped about 5,000 of the previous version of the device. We realized that device just didn't work in this value-based care space. The value-based care space, really, they needed something that was quicker, easier to operate, and was more portable than the device that we currently had.
So there was a drastic need for a product that addresses the value-based care. I want to double click on couple of things here, if you don't mind. So what was very specific to value-based care, because that is a concept that is of interest to me as well. And what was that specific thing that the older device did not address that the new device was able to address, very specific to the value-based care model?
So in the value-based care space, we saw a different type of audience. One of the phenomenons we saw were that payers had challenges with certain patient populations. And these were patient populations that these are people that typically don't go to the doctor on an annual basis. Payers engaging in value-based care, delegated medical groups engaging in value-based care need to find a way to get in front of these patients. So what they will do is employ the services of a nurse practitioner, physician assistant, or sometimes a provider to perform a series of assessments to get a better picture of that patient. Typically, that's something in the past that you go to the doctor and they get an assessment during the annual wellness visit or other encounter. but payers are still taking on the risk of patients who may not go to that annual wellness visit. So what they would do is they would go out and meet that patient at home, and that helps them
Uh,
stratify that risk and figure out, who are my super users, who are going to be my super users next year. And by super users, I mean people that are going to use a lot of healthcare in the near future, the people that are at a high risk of showing up in the emergency department next year. There was really a lot of interest there. So these nurse practitioners, we had a device that was about, I'd say, roughly the size of a shoebox. That was too big. That was too bulky for those folks that are going into patient homes. So we made something that instead of having to pack it in a backpack, it fits into your pocket and you could
well,
just pull that out. Yeah, plug it into a laptop and get immediate testing in 2 minutes and get immediate results as well.
that's a remarkable jump from a device that is the size of the shoebox to something which is the size of a shoehorn, right? It is really
Exactly.
bring it to something that small. And you did allude to that it is faster as well and more efficient and everything. What was the
Yep.
technology change that allowed you to do this? What is the basis of it? What was that core that remarkable development?
We fundamentally changed the sensing technology in our devices. And that was really, part of really having to drastically change the form factor of our device. That's really what drove me to say, hey, we need to kind of rethink not only what the device looks like, but how does a user interact with the device? How do we collect the data? How do we provide insights from that data too? So that really was a kind of a big part of my pivot into really focusing on product in addition to marketing. One of the things that we changed was the sensing technology. So our previous device used a combination of blood pressure cuffs and other sensing devices to help assist in the diagnosis of a chronic condition. And we had, through these other sensing devices, the ability to collect reference data and to feed that data into data science technology and develop a way for, instead of needing someone to look at, interpret the studies, we now had a way to, through data science, deliver insights of the results of that test immediately. So that nurse practitioner, instead of having to wait for a specialist to potentially interpret a study, they can get results immediately. And then they also have the ability, it doesn't just stop there, that result goes to a web service platform, and then other stakeholders can access that data, deliver care plans, follow up with patients as appropriate.
But I have a question for you and in your experience. And normally, I guess you completely redeveloped the product. It was not something large thing that you modify here and there and make it small. It was like completely reinventing, like producing a new product. But for something like this, instead of hiring your own marketing director into VP of product development, you would probably go hire, that is the thing. But what was that compelling factor that it so happened that the marketing director had to take on this role of
Yeah,
product
that's a good
development?
question. We are actually a pretty small company. So, one of the things that I've always heard, and this is actually kind of paraphrasing from Seth Godin, who's really kind of well known in the marketing community. If you don't have a great product, start over. And I wanted to make sure, if I'm going to be marketing something, I want it to be a great product. So I just kind of took the reins and decided that was something I was going to do. My background, I've always been really familiar with technology. My father was in information technology growing up. So I was one of the first kids in my school to have a computer. So that kind of stuff is kind of second nature to me. And I have that kind of natural curiosity. It's the same thing back when I was at Miracle Air. I was tasked with educating international leadership, our country leadership, and a network of independent business owners of the value of online marketing, search engine optimization, pay per click, social media marketing. And this was quite a ways back, but that was new territory at the time. So that new technology, that cutting edge technology has always been an interest to me.
That's awesome. And it was not necessarily a mind shift at all for you or mind change at all for you, but it was more or less like going back to your familiar grounds, I would imagine. So in your LinkedIn profile, you list publications on collaborative care networks and community-based collaborative care. This suggests a passion for ecosystem, not just the device. What does this passion for connecting the dots between doctors, specialists, and patients come from? personally. You can go back to like perhaps your childhood or anything, but I
Yeah.
would want you to go back far enough that where does this interest in healthcare comes from? Where does this connecting the dots, that inspiration comes from?
Kind of early at my time at Biomedics, talking to an interventional radiologist who told me a story. And Biomedics has been involved in collaborative care and this community-based coordinated care model. And it was interesting. He told me a story about the value of being able to see data in almost real time. We're solving this problem of primary care might not be intimately familiar with how the vascular system works because they have a million other things that they need to do. But it's really important to screen for some of these cardiovascular conditions to try to detect them early. So going back to that story with that interventional radiologist, he told me a story of he is sitting at his desk and he is reviewing studies. And these were studies done on a patient a couple miles down the road by a doctor who's not in the same office, not in the same organization or anything like that, but reviewed one of our studies and took a look at the patient studies and said, this patient is in danger of losing a leg. And immediately called that doctor and referred and actually kept his office open late in the day in order to see that patient immediately because he knew just how emergent that situation was and was able to save that patient's legs. I mean, I've
Wow.
even seen that in diabetics. They help control, manage that disease and keep further complications from developing really does require a multidisciplinary team. Knowing, having these teams of doctors, which could include a nephrologist, a podiatrist, a primary care physician, a cardiologist, getting a full picture of that patient and knowing that patient's story is really important to drive the clinical decision making by that team.
That's amazing. Like that brings a big part of the connecting the dots, and also now kind of the primary doctors have access to this specialist as well because of this whole system. For our listeners who might not know Biomedics, Biomedics operates at a critical intersection of diagnostics and data. Can you explain the core offerings of Biomedics today, and how are you helping providers identify polychronic conditions and social determinants of health in a way that actually changes patients' trajectory? What makes you different from everything else in the market, essentially? That is
Oh, okay. Yeah.
a deeper level question, sir.
When I started at Biomedics, our main product offering was called PadNet, which uses a set of blood pressure cuffs and other sensing devices to help identify issues with the vascular system in your legs and feet. And that was something that was already kind of in play when I was there. And since then, we decided to pivot into that value-based care. And the development of that new product was called PadNet Express. So we wanted a name that kind of leveraged that PadNet name, while also representing that this new device was smaller and quicker, a more kind of abbreviated way to be able to figure out who really qualifies for a vascular consult. That device determines whether or not there may be a circulation issue, but it doesn't tell you where that blockage in that leg or that foot may be. So that was really, those are our two core offerings is PadNet Express. When we were launching PadNet Express, it's kind of an interesting story. We were kind of ready to go to market and we had a marketing budget to support the product launch. And it was about a couple weeks before we were going to go to a pretty significant industry show and really kind of make a big splash there. And COVID hit. The in-person shows stopped, which was really kind of core to our marketing strategy at the time. And so what we did was we said, we have this money set aside for the launch. We don't know when the end of COVID is going to be at the time. So my idea was we had this vision for a long time that we never realized. And we took that opportunity to say, let's develop an all new platform that helps aggregate multiple diagnostic studies into a single patient record. So that is a web service platform that we call Biomedix Exchange. That enables risk-bearing organizations to be able to collect data on, it's going to be a long list here, but peripheral artery disease, chronic obstructive pulmonary disorder, peripheral neuropathy, diabetic retinopathy, osteoporosis, depression disorders, personality disorders, assessing fall risk, and collecting data around social determinants of health. So we have a way to be able to, this application runs on a user's computer, and they can use third-party devices that we support to perform these additional diagnostic studies. So they can use our device to collect data on peripheral artery disease, and then they can use a spirometer made by a third party that partner that we have, and they can do a pulmonary function test or a PFT test. All those studies get swept into our cloud service platform. And now a medical director who may not even be nowhere near where the testing is actually being performed, and say, if Chris Trygstad had a PAD test, which was normal, and had a COPD test that was abnormal. So I'm going to customize my care plan and my clinical decision making appropriately.
So I just noticed as I was listening to you mentioned COPD and osteoporosis and other diseases, and they all do not seem to have a common thread, at least in my head. Why these particular very specific diseases? What was the common thread that I'm not seeing?
So we did some market research. We talked to some folks that we knew in the value-based care space, and we said, what are the tests that are important to your space? If you have this patient population and you are taking on risk for these patients, what would be valuable for you to know about that patient? And that's really what we came up with. I guess the common thread here is a lot of these are impacted by lifestyle factors, but more importantly, these are chronic conditions. So
Okay.
chronic condition is something that's, if it's unmanaged, it is typically fatal to the patients. And we know that those chronic conditions drive a lot of costs into the healthcare system, and they'll drive a lot of costs into that delegated medical group or that risk-bearing entity. And we knew from our experience working in the peripheral artery disease space, which is one of those chronic conditions that progresses. And we said, if we, just like cancer, if you detect this condition early in the progression of it, there is a wider range of lower cost, lower risk interventions that provide a wider range of outcomes. So, for example, for peripheral artery disease, if I detect that you have a blockage in the artery of your leg early in the progression of it, so maybe it's, let's say, 20% clogged, what I can do is enroll you in a supervised exercise therapy program and maybe a smoking cessation program, and I can slow or stop the progression of that chronic condition. Now, if you came into a specialist office and you had a 90% blockage in your artery, you're probably going to have some sort of procedure. And procedures, include planting balloons or stents, other ways to kind of get that plaque out of the body or mitigate that plaque somehow. That obviously involves anesthesiology, putting the patient potentially to sleep or partially to sleep, and then cutting that patient open. And I've seen plenty of people that have had an amputation as a result of this. Thinking about patient outcomes, thinking about quality of life. Once a leg gets amputated, it's not coming back. So it's really not good for that patient. It's not good for that quality of life. Things like amputations really drive up mortality rates and healthcare costs as well. So if we can get to those patients earlier, most importantly, we improve those patient outcomes, but there's also benefits in bending that healthcare cost curve.
So one thing I want to touch upon here. So this is almost looks like predictive and preventive treatment, and there is a perverse incentive for system to pay for acute diseases, not a preventive disease, or prevalent diseases, not rather in a preventive sense. How do you make sure that we get paid for this kind of products? Like, what is your argument behind it, or what is your value proposition? For example, a big health insurance company, right? Hey, spend so many $1,000 that will save money. But they will say that, okay, by the time this patient feels is sick, there might be another plan. So why should I spend now when I can actually defer it for
Yep.
later?
So if you think about the employer population, and it's typically thought of as the commercial population, you do see that phenomenon of a patient going in and out of a healthcare plan in maybe 3 years. So if I'm a commercial payer, I might say, you know what? I don't want to know if you have peripheral artery disease because now I have to start treating it. I know most likely you're not going to have negative impacts from it. So I would rather just wait until you move on to the next healthcare plan, and there's potentially better outcomes by kicking the can down the road. With Medicare Advantage, and we typically have found a lot of success targeting plans and value-based care organizations that target the Medicare population is that they tend to stick around a little bit longer, number one. So there are some actual cost-saving benefits in crafting care plans around these chronic conditions. And there are other, I would call them sticks and carrots, financial incentives that fall outside of that traditional reimbursement structure that help incentivize those risk bearing organizations, including the health insurance plan that you're talking about with senior age population. Programs would include the risk adjustment program. Another program is the STARS program. And there are metrics and the identification of chronic conditions that help impact the financial performance of that plan. And then they can use the performance to help drive those patient outcomes and have a multiplying effect down the road where you use risk adjustment, you use STARS reporting, and you have now money that you can use to drive those better patient outcomes.
So this is the same question, but from a provider's perspective. I think
Uh,
providers are already busy treating patients who are already sick. How do you convince the providers to spend time on treating patients who can be sick in the future? And what is the value proposition, or what is the story there?
There's a lot of, I would say, benefits now that a lot of these physicians, and we still love working with independent physicians, but one of the trends that we saw are there are many physicians that are kind of joining forces in other risk bearing arrangements. I'm not sure if you've heard of IPAs or independent physician associations, clinically integrated networks or CINs, or accountable care organizations like
Yeah.
ACOs. And they're part of that group. And the leadership of that group provides the incentives for that. First of all, they fund the equipment, and they then also provide the incentives to do the testing. So that doctor who's now employed may have an incentive structure that encourages him to do the testing. But you're absolutely right. These physicians, I think we continue to kind of underinvest in primary care. There's been some measures when you see the physician fee schedules come out that attempt to rectify that. I think more needs to be done. But we really kind of focused on, first of all, what is easy to use? And second of all, what is something that doesn't need to be done by a doctor, but could be performed by a medical assistant? So our devices can be done by a medical assistant. We talked about the home environment, and oftentimes in the home environment, it's more appropriate to have an APN, like a NP or a PA, kind of, I don't know what you'd call them, practice advanced practitioners, not necessarily
Yeah.
APP, exactly. Yeah, so not necessarily an MD or a DO, but they still are considered a provider.
Basically, you're finding the people who are coming to you and they're trying to find the solutions, and you meet in between. It's not that we are trying to convince everybody to do this, and sometimes it may not be the best way to go. I see the value of this when you have organizations, big organizations like this, looking for these solutions, and hey, we are here. So
Oh
you
yeah, and
help.
that
Yeah.
honest, we are trying to encourage everyone to do that. So we actually work with a number of industry organizations,
Okay.
and we've been talking to staffers in Congress and the Senate about, and this is really more focused on peripheral artery disease, but trying to figure out, are there legislative paths to help encourage or motivate providers to screen patients? One of the challenges with peripheral artery disease testing right now is that a patient needs to present with a primary indication or a symptom in order to qualify for reimbursement. We think that there is a path to support screening for at-risk populations. And we think that that has the potential to not only improve patient outcomes, but also reduce healthcare costs. This is the disease that, disproportionately impacts communities of color, including Native Americans, African Americans, Hispanic populations. It's disproportionately impacting rural populations and veterans as well. So we do see some real value in doing some of that kind of advocacy on Capitol Hill.
So you helped spearhead the Biomedix pivot to digital health for value-based care. Pivots are notoriously difficult and often painful for organizations. What was the biggest challenge you faced during the transformation, whether it was technical hurdles or changing the company culture? How did you overcome it?
The pivot, like any pivot, it is challenging. We had to rethink the way that the nomenclature we used. So even something like I have used the term member and patient interchangeably in our conversation today. When we talk to a physician or a doctor, they're typically thinking of the people that they're seeing as patients. When we're talking to a value-based care organization, they're thinking of their constituents as members. So even little things like that we had to change. And then it's really setting expectations. So in the past, we were selling kind of a big device and it costs thousands of dollars. And we said, what, glad that you bought it. We're continuing to service that and we have service contracts to continue to support you. But it's usually kind of a one and done transaction. And hopefully in 5 years, you'll upgrade to the latest device. So we really changed not only the product, and we made a couple big changes. So one of the big changes we made was we don't sell the PadNet Express. We offer that as a rental.
Uh,
So completely different. So we had some challenges with, first of all, leadership being marketing in a B2B capacity, marketing in a B2C capacity. I knew a little bit about the differences of those audiences. When we think about that individual physician, I think of that as almost a B2C customer in that a price promotion, another phone call, maybe that's going to get that doctor to sign on the dotted line and buy that device that day. But in a B2B environment, we had to set expectations and say, what sometimes that sales cycle, which we're used to it being 1, 2, 3 months, are going to be 1 and 2 years because there's a lot of stakeholders. You got to get a lot of buy-in. You got a lot of boxes you got to check. So we can't think about this on a month-to-month basis. We need to think longer term. And then we need to change our salesperson's thinking. If you think about device sales and the way that you approach that in a B2C environment, when you're selling a piece of capital equipment, you get a commission check after you sell that device, which is great. And I'm not going to come and tell you, hey, I want you to sell these rental devices. And instead of getting dollars, you're going to get nickels now. That's a change because they're coming back and they're like, well, you're asking me to take a pay cut for the same amount of work. But it really took a lot of time before they realized people are more willing to rent devices. It's an easier transaction. And a lot of the times when they like our device. So once they get that device in their hand, they will gladly pay for that month over month. So the customer gets a benefit because they get that ongoing support and they don't have to make that constant decision. It's going to be in their office. They're going to get software updates as we continue to improve our data science, new features and functionalities. But the salesperson also benefits in that they're thinking about that monthly check, right? And they start at zero on the first of every month. Now they're not starting at zero at the first of every month. They know, hey, I have some of this recurring revenue and I have this opportunity to grow my pool of recurring revenue by engaging not only with my existing customers, but also potentially new customers.
that's brilliant, and that takes care of renewing the device and having the customers buy new software or anything. It is a spectrum. So beyond the device itself, do you charge extra for the data? I know you rent the device, but is there a membership for the use of the data and your servers and everything? Okay.
No, we decided to include that in the device. So most of the time they will get our device. We are
Okay.
starting to get some customers that are seeing kind of extra value in our web service platform. And they're saying, we want to use your web service platform, but we don't want to use your device. So we're starting to get into some of those engagements because we've seen the challenges. I'm a medical group and I have 50 clinics and I want to integrate that with my EMR, or I want to see how many tests are being done with this other device. Who knows what chronic condition that is? There really isn't an easy way to do that right now. So we have developed that. So those 50 clinics, you can tell, this person did this many tests this last week, and this person's had a bunch of abnormal studies. I got to see what's going on over there. And wow, look at this, look at this member. They have a really bad test result. When I'm looking at it, I need to contact them and get them into a specialist. So it really kind of takes away some of the challenges of when you have these disparate points of care and you're trying to manage that from a central location. We help solve some of those problems.
And that's phenomenal because now, because of this acquisition of health systems, we do end up having like multiple EMR, and even though it is the same system, it cannot communicate. So this is slightly above platform so that it can communicate with every. Was that intentional from the beginning, or it just happened?
No, it was intentional from the beginning. We saw
Okay.
a value. If we let's go back to COPD, I buy 50 spirometers, put them in 50 clinics. I'm going to have to set up 50 pipes to my Epic EMR. That doesn't sound like fun, right? Because I
Nope.
have to individually contact each clinic and get that all set up. Instead, everything syncs to the cloud, and I set up one pipe. We recently
Okay.
had a customer who we went live with, and they converted from one EMR to another. And I don't know if you've ever been involved in those projects, but they are complex, and there's always a lot of struggles. And they kind of told us one of the easiest parts of the migration was converting, our pipe over to their pipe. And what's nice is, they have hundreds of our devices. And instead of having to convert, 100 interfaces, they had to convert one.
That totally makes sense. And it's like the go live is a word with the EMRs and going into a new EMR. That's like a whole
Oh,
process.
yeah.
It's like, yeah, the Serengeti migration event. It's like huge. All the data points running from across one place to the other and so much chaos.
Oh, yeah. Yep. I've been in those war rooms, the midnight calls, and they're trying to do the cutovers and they're checking everything. So, yeah, it is. It's not easy, that's for sure.
As the as the data protection officer, you sit on the hot seat regarding patient privacy, and in an era where we need more data sharing to improve care, but strict, stricter controls for privacy. How do you balance those two opposing forces at Biomedix?
Be totally transparent with you. We got some work to do on that. I think you're right. Efforts like TEFCA and things like that are starting to encourage this data sharing. We have not really got involved with that, but we do envision a future where, going back to peripheral artery disease, that test result, the patient should be able to see that. The health insurance company should be able to see that. The interventional cardiologist should be able to see that. The primary care physician should be able to see that. And we will get to that. Right now, we've really kind of focused on maintaining our heart trust compliance, which is definitely critical and was kind of a big achievement for us organizationally. And from here, it's just really how do we navigate the permissions and making sure that the right stakeholder has the right information at the right time.
So it's essentially we are not yet ready to have patients have direct access to the data yet. So we are a little bit more constrained for to make sure that the data is secure. So looking at it is there a specific win that stands out to you? Perhaps a specific partnership with the ACO or deployment of your SaaS platform where you saw the data come back and realized we just significantly improved the quality metrics of this entire population. Is there a story that
Yeah,
you share at the dinner table, planning on sharing at the dinner table at Thanksgiving?
I'll share with you two stories. Probably, I'll share one of my favorite ones first. Is we were working with a risk-bearing organization, and we talked a little bit about screening versus just testing patients with symptoms. This is a risk-bearing organization that decided to screen their patient population for PAD, or peripheral artery disease. They tested a patient. The patient was not experiencing any of the typical symptoms you'd see from that disease. And regardless, they referred them to a vascular specialist. And that vascular specialist did a more comprehensive, I'm going to use an industry term, a vascular workup to really fully evaluate their system, their vascular system, make sure everything's working all right. When they went into that specialist and they did that whole battery of tests, they found out that in addition to having disease in their legs, they had cerebrovascular disease. So those are these arteries that kind of run into your brain. So when those get blocked, bad things happen, obviously. And that nurse practitioner told me that story. And to her words, she said, we saved that patient's life. So I thought that was really kind of important to me and underscored that importance of screening. So the other one was we support a device that identifies peripheral neuropathy. And we found out that oftentimes with peripheral neuropathy, that test is only done on one leg. So it could be just the left leg or just the right leg. But since we had access to all the data, we saw that they were also doing PED studies only on one leg. So we reached out to clinical leadership and we said, it seems like this user is only testing one side of the body. We really, from a clinical perspective, think it's important to check the circulation of both legs. And they came back and they said, you're right, Chris, that doesn't seem right to me at all. But we're able to figure out the device, the user, the period of time in which they're doing that. We were able to reach out to that nurse practitioner who's doing the study. Come to find out, they said, the peripheral neuropathy test is only done on one leg. And I just thought it was the same thing with PAD. So we were able to educate that NP to make sure that they're checking circulation on both of the patient legs. So we're able to, from our web service platform, really help that risk bearing organization improve those testing protocols even.
And I hope this was an isolated to like one person and one incident and one institute. It's not a general practice, right? Testing only one leg.
Yeah, you're right. It was one user at one organization,
Okay.
but we were able to see that data and we're able to say this doesn't look right,
Okay.
and be able to proactively reach out to that customer.
Yeah, and they're probably testing 10 to 20 patients every month, high risk patients, and you're missing half the data essentially.
Yeah.
Yeah.
Yep. So we were able to catch that early. Otherwise, you're thinking maybe 6 months you're going to figure that out. Well, how many patients have
Okay.
been tested incorrectly? Do you got to bring them back in? Are they going to want to
Yeah,
come back in? So it's really
exactly.
important that you get that full patient data when you're in front of them.
So, value-based care has been a buzzword for a long time, and in pharma, at some point we're discussing like it's very difficult to pull through value-based care. There are too many stakeholders, and how do you convince value for all the stakeholders and convince all of them? But adoption can be slow. From your vantage point, what does your future of value-based care look like in next 5 years? Are you finally going to see the full shift away from fee for service, or are there still major roadblocks ahead?
Feel like we are moving in the right direction. We're trying things out. When you look at the innovation centers that are really looking at these different models, there are some successes. ACO has proven to save the healthcare system money. I'm a big fan of the PACE model as well. I think those are both kind of great models, especially for targeted populations. I think one of the challenges right now is you have organizations that are thinking in quarterly increments because they may have earnings calls, they have numbers to hit and things like that. And when you think about value-based care, you need to have a longer window of time in which to evaluate performance. So for our disease, going back to, we just talked about that turnover of patients switching insurance plans, that PAD, just like COPD, that's something that progresses over 10, 20 years. So it's going to be a while before organizations are going to be able to say, this is really having an impact on the cost of care, not necessarily revenue, but I'm actually able to move the needle on the cost side of the equation. So that'll take a while. The other side is specialists. I think that they are starting to, that is probably underpenetrated in terms of engaging in value-based care. When you think of value-based care, you're typically thinking of insurance companies, primary care physicians, things like that. But the world of cardiology, radiology, things like that, there are some models that are out there, but I think more work needs to be done there. I'm just recalling a show I went to where they were trying to implement value-based care with specialists, and they would give them kind of a portion they would give them kind of a bucket of money to account for their patient population. And that was supposed to fund all the treatment for that patient population. And then they wouldn't be paid in procedures. They found out these doctors, they get the money and then they do the operation and they expect to get paid again. There needs, yeah, so there needs to be more, I think, just a better communication and expectation, or maybe even a different model. I don't know if it's going to be, a capitated per member per year model in that space, or if it's maybe really episodic in terms of improving patient outcomes and saving costs by delivering appropriate care.
That
Yeah.
almost seems like pretty tricky. You give them money firsthand, and then there is an expectation to pay against. They're basically everyone is coming to job in the Ferraris, and all of a sudden, hey, what happened here? It's like, oh,
Yep.
yep. So you have experience in entrepreneurship, innovating with from within an established company. What is your advice for entrepreneurs or leaders who are trying to drive digital transformation inside a legacy healthcare organization? What is that one mistake they must avoid?
One of the things that I've seen as pitfalls, not necessarily with the projects that I've done, is you need to understand if you're engaging in a digital transformation project, and it could be healthcare, it could be outside of healthcare, the people who are going to make the decisions are going to be the ones that need to understand the benefits. The most obvious benefit are the business benefits. So think about that investment and that money you're asking for that digital transformation, and you need to develop a model. And maybe it's not perfect, but you need to demonstrate, Here's what I think the return on investment is. Here's my reasoning for that. So if you're going to the CEO and you're asking for $1 million, it's not just because it's cool and you think it's awesome and patients will like it. It's going to return $4 for every dollar we spend on this. So really, not everyone has that business background, but you need to kind of be able to speak that language of business to figure out what are the qualitative benefits or quantitative benefits of the investments that I'm asking my organization to make.
And with that comes, finally, you have mastered the omni-channel strategies as per your records. And how should new founders think about reaching their customers today? Is there enough to have great tech, or is the battle won how they tell the story? Because I think the storytelling in value-based care is such an important, and I think healthcare too, to differentiate yourself. What would be your advice there?
Telling that story is really important. So getting your elevator pitch and your story of like, why did you start this company? Why did you decide to do this is really important. So be prepared to speak to that. And I've had experience working with Google AdWords, Facebook advertising, and things like that. That's one way to get the story out, but don't ignore community. Don't ignore going face to face. We found a good community or a set of communities, and we went to those, trade shows. We traveled, we got that story out, and it was through face-to-face communication. We live in a digital world. You were just talking about digital transformation, but people need to see you. People need to shake your hand. People need to look you in the eye. So getting in front of these people, whether it's through a trade show or some other method, is really critical to start building some of that trust and that buy-in from potential stakeholders.
Thank you very much for your time. So with that, I truly appreciate your time, Christian.